Good morning, everyone. I thought today we could just spend a little time, especially in the new era of 911 and 988 and familiarizing individuals and families, that we could talk a little bit about navigating psychiatric crises and how to be supportive and making sure that families and care partners are feeling prepared should a psychiatric crisis arise. So by the end of this talk today, just talking and being prepared to sort of identify the role that care partners play in psychiatric crises, the phases of a psychiatric crisis and what can be done at those increments, and then also how we can be supportive of families in preparation for, during, and after a crisis. So psychiatric relapse and crises, unfortunately, symptom relapse, as we all know in this room, with psychosis, it's a common but unfortunate, event that will happen for most individuals. Part of the wax and wane of psychotic disorders. These mental health crises, psychiatric crises, are really stressful and upsetting for individuals, but also for the people around them that support and love them, especially if they were there at the time that the psychiatric crisis occurs. But really, family and care partners are a critical ingredient in both avoiding psychiatric crises and managing a relapse should something like that occur. Family systems are really impacted by a crisis, but also they can impact an individual's trajectory towards or away from a psychiatric crisis. So we have this really nice sweet spot to work with family systems about things that they can do. Oftentimes there are communication pitfalls amongst all family systems, right? And so when you have somebody that's in the system that's living with psychosis, and there are these common sort of interactions within the family system, and this leads to stress and tension within that family system, and that leaves everybody feeling kind of negative, down, frustrated. But especially for the individual living with psychosis, when that stress and that tension builds and builds within that system, for the individual, this can lead to symptom increase, which can lead to psychiatric relapse, crisis, hospitalization. The problem is, a lot of times family systems, family members, care partners, they don't know how to effectively prepare for a psychiatric crisis or manage those crises. So true to form, that's where we come in as mental health providers. So this is a space we can really do a lot of good work. So when I think about psychiatric crises, I think about them sort of in these three phases or stages: that before a crisis occurs, and that's our opportunity to do some prevention and preparation, the actual moment the crisis is occurring, and then the follow-up. So what's going on immediately after that crisis occurs, and then over time, because even though crisis averted, there are still steps we need to be taking to support family systems to avoid that happening again, or to have them better prepared should something happen again. So thinking about in that before phase, prevention really is key, because being prepared can help everyone, not just the individual, feel better able to respond should a crisis occur. This will lead them, especially family systems, to have less anxiety and feeling that they are better empowered because they're better prepared to handle a crisis should it occur. As mental health providers, we have this opportunity to help them understand their role, and that there's a lot of power in prevention or avoiding crises. So what can they do in the lead up time before a psychiatric crisis occurs? One is understanding what the individual is living with. What is this psychosis? Having that really solid understanding of that individual's experience and their personal experience with psychosis. Because if we know what is sort of triggering or cues that person in their environment, what causes them stress or distress, their family systems are better able to be supportive and create a healthier, calmer, safer environment. Family systems can also help support treatment adherence, whatever that looks like for the individual. But first, they have to know what the treatment recommendations are so that they know how to best be supportive. So again, pulling them into the fold before a crisis even occurs. So as early as and as often as possible, involving that family system whenever that's, a comfortable option for the individual. When a family understands what the individual is experiencing or living with psychosis, they are better able to identify the symptoms earlier on, which means they can intervene before a crisis occurs. And we'll talk about that in a moment. And then also they know better who to call and when, because the first call shouldn't be 911 or 988. There should be a number of calls that are happening, or could be a number of calls that are happening beforehand if we catch it early. And if we tell them, like, if we offer them support and education about how to catch it early, what to look for, what are those identifying signs? And being prepared, help families, again, knowing who to call and the phone numbers based on the circumstance. So am I just call and understanding the threshold. So is this a true emergency? And we're going to talk about the difference between emergency and crisis. But is this an emergency call where there's a threat to life or a physical danger? Versus, is this a call to 988 where we need some kind of counselor resources response to a psychiatric crisis, but it is not a life-threatening event? And how to help them understand that nuance so they're getting in touch with the correct system. Or is this an opportunity to call the emergency clinic or the crisis stabilization unit or, mental health responders? But they have to know what's available to them at that serving agency or in their county. And again, this will look different for everybody, but I think the most important piece is helping them understand, okay, so what constitutes these varying levels? And I think two of the most important things that family systems really need help understanding is calling the provider or treatment, the agency as early as possible. So when you're starting to have questions or concerns, or you're recognizing that something is shifting, call, versus when do I just monitor the situation? So if the person is mumbling to themselves, and this makes me uncomfortable as a family member, but this is something that they commonly do, versus they're mumbling to themselves and now they're starting to pace. And every time they start to pace, that seems to be the turning point where things start to escalate. So helping them find those patterns and understanding that I can watch this, but when this occurs, this is when I should make the call to the agency. Because if I can get a hold of somebody at that agency, they might be able to squeeze that person in. A provider at that agency that day might be able to squeeze somebody in, or at least do a telecommunications call with somebody that during the day, so that they know what's going on and have the opportunity to intervene before a crisis ever occurs. Also important is to help families and individuals understand the policies and procedures of the agency that the person seeks help through, knowing the history of the individual psychosis experience and what the current circumstances. So what was the event leading up to the individual starting to feel symptoms starting to increase, them starting to feel, more uneasy or more distressed. And then talking with family systems about their role in preventing and managing crises. I think a lot of times care partners think, I'm with the person, I'm here to make sure they go to their appointments, try to get them to take their medication, and I'll call 911 if it becomes, if that's a need. But they don't understand all of these little opportunities we've sort of been talking about for them to step in to avoid a crisis altogether. So it's a lot of opportunities for us as mental health providers to really be supportive of these family systems and make sure that they have all the tools and information they need to best support the family. Being proactive, like we said, that importance of healthy, open communication. Part of that is also shared decision making. There's an aspect in here that I didn't cover because of time, but thinking about psychiatric advance directives, living wills for mental health, RAP plans. All of us are familiar with the Wellness Recovery Action Plan. So having those kinds of things in place so that we know what the individual's wishes are, so that as a family system, we know when a crisis should occur, we have a set plan in place to follow those wishes. So anytime that we can be supportive of the individual making their own decisions, understanding the implications and how you can communicate around what the best possible decision is in these various circumstances, and doing that when things are stable before a crisis occurs, is a really powerful tool. And then having plans in place in addition to the the RAP plan and the psychiatric advance directive, also having safety plans, if an individual has a history of suicidal ideation or attempts, but also relapse prevention plan. These are really nice, preventive, proactive set plans that you can have in place. And if the family system isn't aware of what these things are, it's very difficult for them to know what to do and how to be supportive. So involving the family in the creation of these plans is ideal whenever that's possible. We all know that psychiatric crises, especially with psychosis, will occur, commonly do occur. So during a psychiatric crisis, how can that family system be the most effective? So encouraging again for them to put a plan in place. So a crisis intervention plan that's reacting to a crisis. So what are some of the things that they need to know, to do, and to consider as soon as a crisis starts to occur? And then some different things that I want to talk in a bit more detail about is calling 911 versus 988, what information that they should be sharing with the dispatcher, and when they call and are speaking with a dispatcher, requesting a CIT trained officer come and respond if they do call 911. So when calling 911, I think the most important thing for families to understand is that it's an emergency. This is an emergency, a life-threatening situation that involves an immediate physical danger. So if there's any kind of medical emergency, a threat to life or safety. And this is when law enforcement will be dispatched if there is potential for violence or criminal activity. So yeah, along with the EMS, sometimes law enforcement will be dispatched. But immediate intervention is necessary in order to provide life-saving intervention. So that's the key with 911. And it's a response system. 988 is called the 988 Lifeline, the Suicide and Crisis Lifeline. And it's really for behavioral health crises, so not emergencies. So the crisis is not immediately life-threatening. So they might be thinking or talking about hurting themselves, but there's no plan, there's no weapon in hand. They're not sitting with pills, ready to take them. They've engaged in some self-injurious behavior, but it's not immediately life-threatening. They might be experiencing severe emotional distress. They're engaging in problematic use of substances. But they're in the space here. And I think this is what families need to understand. The difference between that emergency and that crisis is that it is not immediately life-threatening. And I think that can be really confusing for families. When 988 is called, if a family member calls 988, they'll offer real-time support by trained crisis counselors. So they can offer resources. It is anonymous, it's confidential, it's 24/7. You can access it by calling, chatting, or texting. So it's really an avenue to engage or support that family member, or to help them provide them with some direction about how to get the individual to engage with services or get the supports that they need before it turns into an emergency situation. So this is sort of the precursor step before something becomes life-threatening. And so this is a really new space for people to get used to. We all know 911, and that's typically the default. And so how to better utilize 988 and get that better response. And the goal is to really avoid unnecessary involvement of law enforcement or EMS, but especially law enforcement. So this is the opportunity for families to intervene a step before a true, life-threatening emergency. So I put a couple of documents in here that you can find this one's from SAMHSA 2024. I put the link included at the end of this resource, because the next couple of slides are just great little handouts to have if you're seeing an individual, or if you have the opportunity to talk with a family system, just making sure that they have this information in hand so that they better understand, and having a conversation with them, of course, but what is 911 versus 988? So this gives them a quick preview, depending on which one you like best. This one's available on the Ohio Department of Behavioral Health. This is linked in the resource section, so that if you want to print this out to help family members, there's this really brief one, but bottom line is 988 is for behavioral health crises, 911 are for medical or physical emergencies. So just some little nice tools and handouts to have available for when you have the opportunity to talk with someone from a family system. Another piece that I wanted to take a couple minutes to talk about is information to convey when calling for crisis or emergency services. So, when there's a psychiatric situation, crisis or emergency occurring, The most important information that they convey, the family member or care partner that's calling 911 or 988, these are the things that they need to know so that they know what to tell the dispatcher. This is the most helpful, key, critical information. So, is the current threat danger to self, others, property? Does the individual have current access to a weapon? Does the individual have a history of violence or aggression? Has there been a history of suicide attempts, self-harm, hospitalizations? Do you know the individual's mental health diagnosis? Are they currently taking medication for that? Are there things that you know the person responds particularly well to or not so well to, either people or things in their environment? Are there, things that have calmed a situation down in the past? Because if a dispatcher knows this, she can convey this to responding EMS and or officers. Also, what has made symptoms worse in the past, and is the person currently under the influence of substances? So as much of this information, having the presence of mind to share this with the dispatcher, this is really important. And this helps to avoid some of the things that families are really, family systems are very hesitant to call for help sometimes because they have the fear of what the consequence of that will be. And so to avoid some of those situations, if you know the individual doesn't have a weapon and isn't aggressive, but they're floridly psychotic and they're shouting that I'll kill everyone, an officer might approach that very differently if they know that they don't have a weapon and they know that they don't have a history of physical violence. So really key things to tell family members. Also, families often don't know about CIT, crisis intervention team trained officers. So those are officers who have, 40 hours of training in communicating, assessing, and resolving mental health related crises. Oftentimes they're primary responders. They also know a lot about what connections there are and resources there are in that community. So the other thing is this: if this is a crisis, a psychiatric crisis or emergency situation, asking the dispatcher for a CIT trained officer, or an officer who specializes in mental health emergencies, because that tells that dispatcher, okay, this is psychiatric. We want to make sure that one of our CIT officers, if we have someone on duty, can respond. And the goals of a CIT officer responding is to really improve safety and outcomes because they have a solid understanding of what's happening during a psychiatric crisis or emergency, moving people away, diverting from the criminal justice system so that they can get the appropriate care and support they need from the mental health system. And only utilizing these officers when there's an imminent threat to safety or some serious criminal concern. So again, that's also part of this, is knowing, when I call 911 asking for a CIT officer, when I'm calling 988, we're not at the threshold of that true life-threatening emergency. So likely there's going to be no officer that's going to need dispatch. So helping families understand these nuances, and the better they are able to understand what information to share, what is a CIT officer, the better and more prepared they feel, and the safer they'll feel contacting and reaching out for help, should there be a crisis or an emergency. During a crisis or emergency, obviously, talking with families about trying to remain calm, recognizing that the people that are going to show up know what they're doing. So as soon as they come in, tell those responders it's a mental health crisis or a mental health emergency. Here's the information you need to know, and then taking a step back. What you don't want is families on top of the responders panicking. And so a lot of times having chances to practice with a family system about making that call to 911 versus 988. What information do they share? What do they say when the officer or the EMS shows up? And then also importantly is they're going to witness something that's probably unsettling, and they might see their individual taken away by EMS or potentially taken into custody by the officers. And so what does that mean for them as family members? So obviously, if in doubt, making sure that care partners know to err on the side of caution. If there's any issue of safety, situation must be addressed immediately. If there's any threat to the physical safety or immediate physical danger, always default to 911. And then after the crisis occurs, so they've watched their loved one, they've experienced a psychiatric crisis, they've watched their loved one being taken away by EMS, and they get admitted to a psychiatric hospital, then what? Family members are just kind of sitting, waiting for the individual to be discharged or released. So following this crisis, family members could be doing a number of things. One, taking care of themselves, making sure they are getting support to process that, either from you and or NAMI and or other family members that are supportive of them. But also calling the individual's providers and saying, just wanted to let you know, this is what occurred, and they've been admitted to this hospital. And that kind of cues the provider or the agency in so that we can step in and making sure that they're feeling prepared for what to do when the individual is released. So if you are able to visit, here are some of the things that you could focus on, talk about, think about. Here are some of the things that might be hot buttons that you don't want to talk about while the individual is in the hospital. Talking with the family about how they're coping with what they experienced and witnessed, giving them space to share their concerns about the loved one being discharged from the hospital or released from being held in jail or whatever it was. But getting ready for the individual to come home can sometimes be really daunting and scary for families. And that's sometimes where they say, I don't want the individual to come home. Or saying, of course, they can come home no matter what, when it may be not the safest option. So having those kinds of tough conversations with families are really, really important. When you have an opportunity to process the crisis with family systems, normalizing that relapse occurs, validating any concerns that they have about it occurring again, about their loved one coming home, really taking the time to sort of examine what occurred prior to the psychiatric crisis, because we can learn a lot from that. Kind of walk me step by step and describe what you observed over time, because this will help to ensure stability moving forward, or at least make it more likely, because if we can avoid some of those things that were precursors to the event, that's really useful for families. Individuals and families, of course, are probably feeling discouraged that things got to the place of a crisis or emergency, but talking with them about, yes, that was really distressing. Yes, I know that felt, like that was a big hit and a big setback, but really this is an opportunity for us to learn some things. Let's see what occurred. Let's break it down. Let's build some coping skills so that we can avoid some of these things earlier on. Let's call me as the provider earlier on when these kinds of things are happening, to either avoid a crisis in the future, or at least to mitigate it so that maybe the severity, the impact, and the length of that crisis will be lessened next time. And then also taking the opportunity to say, is there anything that you wish would have looked differently had this occurred again? So what do you wish would have been handled differently? How things that you wish you would have done differently, things that you wish responders would have done differently, as a means to prevent crisis in the future. So overall, most important takeaway for me for this one is ensuring that a psychiatric crisis isn't the first time we're engaging with family or care partners. So as often as we can, talking with them ahead of time. Support family systems and individuals by having these kinds of plans in place, making sure families have information that they need to know about calling 911 versus 988, and then what to do when they call. Also helping them to better understand what to do earlier on prior to the crisis. Post-crisis, making sure that they're in a sort of stable, confident place so that they can process what happened and talk through things to identify how to avoid this happening again in the future. And then making sure that they understand that you are an individual's provider, but as long as it's okay with the individual, you're there to support them too if they have a question or if they want to attend a session with that person. So as I mentioned there, I put on iEcho, there's a handout that describes a little bit about CIT. And when you call 911, those are those things that you could print. It's a two-sided handout, but making sure families know what information to convey to the dispatcher about asking for a CIT officer. So that's that CIT and calling for emergencies handout. It's in the iEcho system along with these slides. Some of the little handouts or graphics that I showed, if you want to have them for families, the first one is the ODBH calling 911 versus 988. And then under SAMHSA, that very bottom bullet, if you click on that link, that will take you to the longer handout that talks about crisis versus hospital, or crisis versus emergency, 911 versus 988. So just some things for you to be able to have on hand to provide to family systems should you have the opportunity, which hopefully you do, to see them before a crisis ever occurs.